A very good evening to everyone, and on behalf of everyone involved in the program today, I welcome you to this absolutely epic meeting, if I may call it, of the Society of Fetal Medicine. It started with an idea which was put forth by Dr. Kanchan Mukherjee for his suggestions for the periodic meetings of the Kolkata regional chapter of the Society of Fetal Medicine. And he said we should have a program on how to report ultrasound scans, and we should have some templates. A very seemingly a simple method of saying, okay, let's put together something. And we had no idea what we were going to go in for because it's evolved so much. So as we always do in Calcutta, we had a group which always meets to decide the content of the meeting. And I don't know whether we opened a can of worms or we opened a garden, not just a bouquet of flowers. And what it seems now is that we seem to be putting together something that was long overdue. We know that when we examine a patient, it's not always a patient that we're going to be treating, and not just a scratched out report on the patient's medical records, but an actual communication of the findings to whomever might use it for clinical purposes. We also realize that not everybody has the expertise to read that report. We also realize that there's several levels of expertise, that there's several types of examination, that we currently have very few checklists. We have between 9 and 12 major recommendations from different parts of the world, all with different levels of expertise, both of the examiner as well as of the machines that are available are being quite different. And so we said, now what do we do? So then we put together a slightly larger group, and we said, this will be an expert group that will do the initial homework, and we will get, as usual, like we used to do for our previous guidelines, we'll get some inputs from our entire membership. So what we did then was to put it out as a Google form to be filled out, and we got some excellent responses. And the next part of the plan was to put all that together, get a core group to sit down, and then make out a plan that we could discuss in today's webinar, which is the first major stepping stone. Once we're through with what we're going to do today, we're going to invite further inputs, and then we're going to have the final task force sit down and put it together. Of course, all of us in the original part of the program today will be on that group, but we will also include others whom we think will contribute. And the most important thing that's going to be here is that these guidelines are not going to be like what we used to do earlier. We used to have a meeting, which was an on-site meeting of the Society of Fetal Medicine, and it used to be either Fetal Cardiocon or it used to be Fetal Med. And we used to put all of this into a PowerPoint and get point by point clarification and then incorporate those. That's not possible in today's day and age. And also, I think to put our membership together would not be easy because we have so many members now, and we don't have a large hall in COVID times. And for COVID times, to put the kind of people we used to get per meeting, we require a hall that is larger than one of the largest convention halls that we have in the country, and which is nice, of course. But then we said we have to serve our purpose, and that purpose would entirely be to put together reporting formats, which will not just be how to write a report, but how should we create a report, how should we do a scan, and what should be disclaimers, etc., which we'll be discussing today. And then after this meeting, we will again ask for inputs from everyone. And then the core group will go through those. Then we will have an expert group sit in. We will have re-meetings as necessary. And then we will put together a set of, we don't know yet whether we're going to call it guidelines, whether we're going to call it a reporting template. But let's see what we come up with in the webinar today. And I really thank Dr. Kanchan Mukherjee and the entire Calcutta team. And thank you, Dr. Kushagradi, for taking this forward, and every single member of the Calcutta team taking this forward, along with the executive committee of the Society of Fetal Medicine at the national level. And let's see what we can come up today. And what we have to achieve today is one step. And hopefully it will lay the stone for a quick, rapid document that will be useful for all of us. So over to Dr. K. Parna Sharma to moderate this. And as you can see, we have a lot of people who are on the panel. You are familiar with all of them. If I were to introduce all of them, we'd eat into very useful time. So without spending time on that, since most of you know most of us, we will go right ahead and start the meeting. So Dr. Parna Sharma, please take over.
Thank you, sir, and a very good evening to all of you. So I'll begin by sharing my screen, and as was being discussed just a few moments back, it is actually a mammoth task that has been started. And we really hope that, the end result will be something which is very, very useful. So we have the experts with us today. We all know Dr. Ashok Khurana, Dr. Bimal Sani, Dr. Chinmay, Dr. Debasmita, Dr. Kanchan, Dr. Khurshid, Dr. Kushagrati, Dr. Meenu Batra, Dr. Mohit, Dr. Pradeep, Dr. Shankar, Dr. TLN Praveen, and Dr. Sita. So we are really happy to take this forward. So essentially, we have put together a list of questions which we will be asking to each one of the experts, but I would invite comments from the others too. And also we would request the audience to put in their comments in the chat box so that we can actually incorporate them and look into them with their inputs. So we'll begin with the first question, and would request Dr. Kanchan Mukherjee to address this question. What are the base minimum requirements for a uniform obstetric ultrasound reporting and documentation?
Thank you, Aparna, for taking over this mammoth task for us. The obstetric ultrasonography, as already described by Dr. Khurana, is an umbrella terminology which covers a lot of different things, and examination being done by various people with different training background and different experience levels. So it will be nice to have some kind of guidelines or template to create a uniform report which would be useful to the users, patients and the doctors, everyone. So in order to achieve that goal, we have to agree on a number of criteria. It should start with date, name of the patient, and it should also identify the operator as much as it identifies the patient. So with those basic information, we must then explain beforehand that what is the purpose of this test, i.e. what is the indication and what are the limitations of this particular test. So the expectation is tuned at the right level. Then we write down the findings, normal as well as abnormal, the diagnosis, and provide some guidance for further investigations or management plan if appropriate. If it is up to the level of the operator, then of course there should be a clear communication to the referring physician. So there is quite a lot in it. Thank you.
Thank you, sir. So I think very rightly put, and this is the most recent statement which has come from the European Society of Radiology. So as sir was saying, Dr. Shukran sir was saying some time back that some of them are really, really old. Some of them have been, some guidelines have been recently updated, and this is one of the recent updates where it has talked about what should be included in an ultrasound report. So yes, mostly things are, and this is like the umbrella thing that we'll be covering over the next 45 minutes or so. So with that, I'd like to go to the next question, and that is to Dr. Bimal. I really like asking you all these questions, sir. But, should the radiologist routinely convey the reports to the patient? This is slightly off topic, but yes, this is something that we really need to know, because when we are writing the report, then we have all categories of people and all branches working together. So should radiologists routinely convey the reports to the patients?
I think, Aparna, there is no 2-second thoughts about this. I think anyone, why only a radiologist, anybody who takes up the responsibility of doing a scan should also take the responsibility of conveying the reports to the patient. There was a time when this used to be controversial, whether a radiologist should discuss the report with the patient or not. But I think those days are over, because now even the branch of radiology is more of a clinical radiology thing. And if as a radiologist, I take up responsibility of doing something, I'm giving the report in writing. It is also my duty to speak to the patient, because these days, the patients, when they come to you, they have come to you because you're a specialist. So, they have not come to a technician where, somebody is just doing the scan and putting things together. And even if you decide that I don't want to speak, the patients are not going to leave you. You will immediately find that they're waiting outside even after the report has been handed over that, yes, we need to speak to the doctor. So that is definitely there. And I think the times have changed. Even clinicians these days expect that the radiologist should speak to the patient about the reports. Again, an important part is that I think everyone also should know their own, level of expertise. You need to take that into consideration that, yes, how much you know about that particular entity that you have documented on paper. If you're not well aware about those things, then then you can always suggest that, yes, you need to go and meet someone and discuss this finding. Maybe they will be able to tell you better about this particular, suppose there is a particular anomaly, and because it just does not end with just telling what it is. The patient is always going to ask you that, okay, yes, how's the prognosis? So you draw a line where how much you want to speak to them. Another thing, only valid point I would like to make is that there has to be a restraint as far as discussing management with the patient is concerned. See, I would always want that to be left to the treating doctor, because, some things like, okay, suggested cervical encerclage or deliver the baby now. I think that is where you need to draw a line. You can always talk to the patient. Suppose there is an abnormality in the Doppler, I would discuss it with them. And at the same time, of course, tell them, yes, you need to go and meet your gynecologist now with this report. I will discuss it with them also. And yes, maybe in a better way, I would say, yes, now she'll have to think over with these findings. She'll have to think about the timing of delivery. But I won't tell I would not like to put my, my statement that, no, yes, you can wait for 2 days, or you need to go ahead and, you need to do a cesarean section, because these are things I would leave to the,
Right.
I think it is not necessarily only about the radiologists. I think even the fetal medicine specialists who are imaging people, who are more into imaging, they should leave the treating doctor to discuss as far as the management is concerned. We don't need to get into that particular aspect. And most important thing is, whatever you speak to the patient, it's always better that you give a call to the treating clinician and you discuss it with them. There is, that communication makes a huge lot of difference. Yes, when I'm talking to an obstetrician, I can say, madam, it's better that we get this baby out now. But I won't tell this to the patient that, no, your baby has to come out now. So I think if you draw that line, everything else, you need to talk to the patient. Because so many times you will have that the person who's doing the scan knows more about that particular entity than maybe the referring doctor also. So
yes, sir. Actually, the basis of my question was that in a review of the medical legal suits that happened for obstetric ultrasound, one of the major reasons was the maternal fetal medicine person did not explain it or did not offer the correct management. So, there, as you said, you need to explain, but maybe draw a line. So, and that is what is very, very important when we are actually reporting an ultrasound report, on where to draw a line and where to refer it back, but yet communicate and inform the patient. So I think that is something which is very, very important. So with that, we come to one of the most important and crucial feature of any report. So Dr. Chinmay, I'd like to know, what is your idea how the report should be? Should be an itemized report, or it should be a narrative report?
Well, thank you for the question, Dr. Aparna. And I think it should be a combination of both. So your report has to be a document of at least 3 to 4 pages. Some of it has to be the measurements and the charts of whatever you have seen. That is a graphic representation and something which is put into figures and centiles for people to just understand, that this is how the growth is. The final report or the impression is what has to be a bit narrative. So you give the itemized report in a tabulated form initially, but you also explain that I feel we have dated the pregnancy, the growth is right now normal. It is better, suppose it's a growth restriction case and it was on the 4th centile earlier, now it's become 6th centile. It continues to be growth restriction, but there is a good positive interval growth. Unless you've added that in the report, there's no value to your assessment just like that. So there has to be a bit of narration. And what Dr. Sani just told us, that documentation of that communication between yourself and the patient and the obstetrician, that also can go into your report. Because suppose the improvement of the Dopplers, the growth has happened and you've looked into the Dopplers, you've spoken to the obstetrician, and then you've taken a decision that, okay, we are waiting for 1 more week and we will see them after a week. Why not put that down there? That I had a discussion with the couple and the treating obstetrician, and after discussing the merits of the case, we've decided to review her after 1 week. So that closes the loop there.
Right.
Because we agree that we have limits as imaging people, but we are not just imaging people. We are a joint team. So it's a multidisciplinary team. We won't be able to sit across the table at all times. So instead of that, we will close the loop in our report. So yes, it has to be a combination of itemized as well as narrative.
Yes, so very nicely put, Dr. Chinmay. I think it has to be a healthy balance between the both of them. But I would also like to know, like organ-wise, the fetal anatomy-wise, would you like it to be itemized or it should be narrated?
Yeah, luckily we actually have solved the issue by using a very sort of composite software which has drop-down menus.
About the places where there is no software.
Correct, correct. So I'm just starting with where we end at, that you go ahead and you have a drop-down menu for each organ. So every scan is done based on certain guidelines and recommendations, which means there is a checklist.
Yes.
So whatever is required on that checklist, that needs to be reported that I have checked this. So if there are 2 orbits, we have checked 2 orbits. Presence of the lens, if that is part of your recommendation, you recommend it. If you've seen 2 kidneys, you've seen 2 kidneys. Whatever is your checklist, that much has to be in the itemized areas of your scan, which an obstetrician should be able to go and see. And I should also recommend that all our people who scan should give those pictures also, so that you can corroborate the pictures that ideally if you could index the pictures, that would be excellent, but in an ideal world that's possible. In a daily routine, that's not. So that doesn't happen. Yeah, that's too much to ask for, but otherwise that would be good. Towards the end, I want a composite narration of that scan and a information to that obstetrician so that she can read it and understand what I mean to tell her.
Yes, absolutely. So, I came across this very good detailed article about what makes a good ultrasound report. And they said that most clinicians prefer a tabulated or itemized reports. They like brevity, but not to the extent where normal is all that is written.
Exactly.
And referrers like to know what has been seen and what has not been seen. So a list of organ and area followed by normal is perfectly acceptable. And the clinician...
sorry to disturb. Let me sometimes tell you that there are situations where you see the kidneys. One kidney is slightly lower than the other. It's not necessarily pelvic, but there is a difference in their position. Now, in your actual tabulated form, you will not get a entity like that.
Yes.
Sometimes the amniotic fluid is slightly echogenic, which doesn't really mean anything. But if you have written this down, that I have noted it, I have seen it, I have not seen anything which is of concern there, then that makes sense. That graph which you just showed there, actually the table should have 5 explanations. So the first one is like normal, where you just say normal. B is where you give a brief prose, and C is where you give a prose with tabulated. D is where you give a detailed prose, and E is where you give a detailed prose with tabulated. So you see most of the people have liked the detailed prose with the tabulated. Yes. So the choice of the clinician is always the detailed prose with the tabulated.
Yes, so we need to have some detail with tabulation, and yet as Dr. Chinmay said, there should be a verbose or a complete narration at the end that what do you mean by this report. So I think that is something that is very, very important. And this is the general components that they have, looked at. General practitioners, what do they want? So all of these are things that we are going to come in further. But yes, clinical scenario, examination technique, quality of examination, measurements of normal organs, recommendations for further imaging, non-radiological investigations, and recommendations for further referral. So these are the things that they have actually
and
wanted.
Treatment as well, recommendations for further treatment as well. Yes. So, we can't jump the gun by saying that our Lakshman Rekha is there and we are not going to move from there, because that's part of our job if we are calling ourselves fetal medicine specialists.
Right.
Yeah.
Very
So,
true.
Dr. Aparna, can I just say something?
Yes.
Like, see, what happens is, I'm just talking about a practical scenario. What we do is, as Dr. Chinmay rightly pointed, by the time we finish the whole report, whether it is a combination of itemized or narrative things, it is a 4 to 5 page document, which becomes difficult at times for the general practitioner or the referring obstetrician to comprehend. So what we always do, and I feel it's a good practice, is we always get a separate letter typed for the referring clinician, where we specify as to why the patient was referred and what is that we have found and what is the next plan of management that we would be suggesting, so that it just does not somewhere gets missed in the whole process. I think that's a
yes. So that's another way of putting things, that you have a report and you also have a reply letter to the referee. Yes, so that is something to be considered, and a different approach.
At the same time, I think you can call up the clinician and talk to them also. I think that will be much more communicative.
Absolutely, sir. Calling the clinician and talking is going to close the loop. And if you document it there, that we have had this word with the clinician,
discussion with the
and then this is the final thing, that closes the loop there only in your clinic.
So I think that is some level of, the next level of communication, and something that we can be encouraged by all of these activities, and that is what we are looking forward to. So we can
normally speak to the clinician before the patient leaves our clinic, so that we call them and inform them that I've already spoken to them.
Absolutely.
Right, sir. So we come to the next question, Dr. Kushagrati. Like, this question is, one of the main questions that we are looking into, and whatever you say, please remember that, people are looking at us. So, what is the optimal? So I'm putting a lot of pressure on.
I know you put me in the hot spot, actually.
Yes,
well, the diverse opinion, I'm sure that you must have got different responses in the Google form. I mean, I can give my idea about that, going by the different people that have spoken to, the clinicians as well as ultrasonographers. The fetal medicine people would like to have as many scans as possible, and the clinicians and the patients don't want. So the thing would be to go by the NICE guideline. I suppose that's the latest guideline that we have in 2000. This year only it has come out, and it really suggests 2 scans basically, one between 11 and 14 weeks, which we all know the window, the first trimester window as we call it, and the other one around 20 weeks. Now, the third point which is written, I'm not so sure whether we should be including in our reporting documentation template format or not. That's something we do not routinely offer. That I'll be open for suggestions. But yes, 11 to 14 weeks can go back. 11 to 14 weeks and 20 weeks. Germany and all some of the European countries, they do say about a third scan. But the third scan is again a controversial scan. I mean, it is not shown very well by any study that routine third trimester scan actually reduces perinatal mortality or morbidity. So that is something which the NICE has not really recommended. So basically, given by, we can recommend 2 scans, which we can call it standard scan. Now, the AIUM actually mentions 3 types of scans. One is a standard, one is limited, one is specialized. We all sort of understand standard, or we are going to understand standard scans in the next webinars when we go for the first trimester, second trimester, and third trimester, so forth. And probably we are going to also have specialized scans like fetal echo, neuro, Doppler, 3D, etc. Now, if we include the term limited scan in our country, we have to be really very careful to define limited scan, what it really means. And maybe there should be a webinar on that also. A limited scan, as we normally understand, is performed to answer a specific acute clinical question. When, for example, there is no time, or maybe it is not necessary to do a very detailed scan. For example, an early pregnancy bleeding, or a pain abdomen in early pregnancy. We just want to know whether it's ectopic or not, whether you can see the sac or not, or maybe decreased fetal movement, or a bleeding PV in late pregnancy. We want to see if it has not been scanned, whether there is a placenta previa or an abruption, etc., etc. So probably it is the expertise is not there for detailed scan. The time is not there, and probably it is unnecessary. In these cases, a limited scan is a terminology which is used in AIUM guideline. Now, I feel that the 14-week scan and the 20-week scan should be mentioned as a standard scan in the documentation that we are going to produce. But of course, people have to comment on that. And we have to make a provision for a limited scan as well, because gradually people will understand that there is a concept of limited scan. And in such a scan, we cannot be actually incriminated if we miss something because of those limited conditions. And of course, it has been written also that whenever limited scan is done, in the next opportunity, a subsequent detailed scan or a standard scan may be done. So I think there should be a combination that we should write that, yes, we should offer 2 scans, standard scans, 11 to 14 weeks and 20 weeks, and other scans as appropriate.
Right.
That is my feeling.
Right.
Yeah, Dr. Praveen wants to say. Number of scans, I would say 2, going up to 4 maybe, 1 for the viability scan and 1 for the routine scan. I would go for 4 scans.
Right. So if you look at the responses that we had, right, so 50% felt we should be doing 4 scans in pregnancy. So maybe they want to include the early viability scan and a routine growth scan. So,
Yes.
and the 3 scans was done by 23.5%, and some of them felt it was 5, 6, 7, 8 scans. Somebody has, so there are various, choices of scans, but some people have already also mentioned that in low risk, it should be 3, and in high risk, it needs to be individualized. So I think these are some of the options that we have received, and regarding the optimal number of ultrasound scans in pregnancy. But as sir has mentioned, maybe we should have 2 standard scans, and also the option for limited scans and specialized scans when it is indicated. So
one article.
There is.
Sorry.
Yes.
Can I pitch
Sir,
in?
please. Yes, sir.
See, I think a growth scan also should be made as a part of the standard scans. In the sense, I don't think we can avoid that. As Ghosh said, yes, 11 to 14 and the mid-trimester anomaly scan, as well as a growth scan, because these are the 3 minimum scans that we need to do. Actually, if you ask me, I think the 3rd scan is extremely important, not only for the growth, but also to the late onset anomalies, as well as evolving anomalies. And there are certain situations where you might not have picked up an anomaly in the 2nd trimester, where you have a chance to, again, have a relook in the 3rd trimester. I think, to me, I feel 3 scans minimum should be there.
Yeah, if it has to be.
Absolutely right.
I think, I think the problem is that we have to differentiate between what kind of a healthcare system we belong to. And unfortunately, in India, there are very thin lines between healthcare systems. The government itself recommends only 1 single scan, which is the anomaly scan at 18 to 20 weeks of pregnancy. As per the old MTP rules, we couldn't exceed 20. The question is, we do understand that that a lot of problems will occur even in low risk or routine risk pregnancies. And therefore, we cannot say that, okay, we will only look at high risk. The second situation that we see is affordability. Unfortunately, because the courts of this country disregard affordability completely, including those of the ones treated free at government hospitals, we cannot just disregard and say that, look, these were the guidelines. What we have to say that, yes, we have these guidelines, you have these options. The system can only offer this much free of cost. And this is the advantage, this is not the advantage. This is standard, this is not standard, and take your choice. So perhaps at the end of it, we'll have to leave it open. The other thing that we have to also consider is that it's going to take us about between 3 and 6 months to finalize what we have set out to do. And once we set out to do it, it's such a mammoth task, we're not going to repeat it too soon. So we have to have a futuristic approach also. So with the kind of information that we've got recently from Kipros's group about the utility of a 36-week scan, and then the possibility of a 30-week scan in a country like India where fetal growth restriction is just so common, do we have to consider things differently? So this perspective we will have to keep when we finalize all of this. So we will develop templates for all of these scans, undoubtedly, and we will have reporting rules for all of these. The choice perhaps we will have to leave open as part of a paragraph and nothing else. But we will see how things evolve over our meetings over the next 3 months.
Right, sir. So I think that was quite comprehensive. Yes, Devas.
Yeah, ma'am. There is an article published in 2019 in British Medical Journal. What actually sir has pointed out is that third trimester ultrasound is justified. There is a question over that. This is the article actually protocol is saying. In actually, it's not about the high risk women. At high risk women, we can very well diagnose about SGA and all kinds of IUGRs in very easily from the very early trimester. But there is an importance lies what sir has pointed out it about the low risk women that is actually beginning at around 32 weeks about late SGA, late IUGRs and all that. So that's why this third trimester ultrasound is very important, including this developing anomalies as well.
Right. So thank
Ma'am,
you.
I think
Yes.
yes, because of some neurological abnormalities formed in later stages of fetal development. That's why it's also again important to do a third trimester scan.
Yes, Dr. Shankar, thank you. So I think Dr. Khurana was also mentioning the same thing. And so, yes, I mean, so this something we have to leave it open and somehow frame that, it is non-controversial and yet it gives us scope to evolve, in the future. So, staying on that thing about the scans, sir, Dr. Praveen, sir, would you prefer as a nomenclature for ultrasound scans in pregnancy? Because there are various terminologies which have been used, and somewhere when we label our reporting document, we need to label it as something. So what are the options that you think of?
I personally feel that there is a specific indication for which you are going to do a scan, and that indication is the one which has to be mentioned in your scan labeling. For example, if you are doing for an anomaly scan, you either call it as an anomaly scan or a targeted imaging for fetal abnormalities, because this TIFA concept has caught up so much that people are very much aware of it and they quite often use this terminology. So for a second trimester scan, you can as well say that it's a TIFA or an anomaly scan, standard anomaly, second trimester anomaly scan. As well as the first trimester, that is 11 to 14, you can call it as a dating scan plus for the first trimester screening scan. And the third one is what you call it as the growth scan. So these are the basic nomenclatures. I think this is already established and it is easy to continue. So when we are incorporating in our reporting formats, I think this becomes much more easier for them to accept and to practice, put it into practice.
Right, sir. Thank you, sir. So the point is when you have things like NT-NB scan, 11 to 14 week scan, and a first trimester scan. So somewhere we need to, of course, give some standard nomenclature by which, the SFM reporting templates will come up.
That's the reason why I said it is either a dating scan plus a first trimester screening. Yeah. And then the second one is the TIFA or the anomaly scan. On the third trimester scan is the growth scan. I think, it becomes much more easier for us to understand.
Yes. So I think, so we have a broad nomenclature, and I think that is what we can take forward and work on it, as we go on. So thank you, sir. So now we come to the next part, which is the demographic details. So how much to include? So ultimately, when we work as a society of fetal medicine, we have clinicians and we have fetal medicine and we have radiologists. So somewhere we might tend to become heavy on the demographic details or the clinical details. So what is the correct measure of the demographic details and how much to include?
Yes, ma'am. Actually, ACR practice parameter for communication of diagnostic imaging findings have laid down some criteria for the demographics. It is first to mention basically the facility or location where we are actually conducting the ultrasound, that has to be mentioned properly. And the name of the patient, that's very important, age, that will be detected by the date of birth, and that should be the way out actually. And the third point is very important. It's about the referring physicians and also about the healthcare providers. If at all somebody is there, like it has been referral center from there is peripheral health center, like in government colleges, they have been referred from those care of centers. So those has to be mentioned very properly. And even if the patient herself has been motivated herself, like, yes, I should go for a first trimester scan, I should go for a growth scan, that knowledge within her mind, that should be explained also, because these are very important for the demographic data, not for the reporting, but after that for the demographic data for some research associations, as well as to conduct any kind of studies, or to have the awareness regarding that society, how much they are aware of that kind of scans, and while referring to the patient doctors. That is very important. And we need to mention, of course, about the name of type of the examination, and also the date of examinations. And the time of examination is very relevant, where actually we need to go through and through, like many a times we need to go for the patient for the cardiac scan we are doing, but we cannot see the heart properly because of the spine is in anterior position. So we have to again and again see the patients, but on that day, same day, we cannot see it may happen. So that's why it is very important to mention that timing, and medico legally also it can be helpful for us. So that's why it is very important. And inclusion of date of detection and date of time of transcription. When we have detected the report, we have laid down the report, actually we have planned, many a times we give the report like 2 days after or 1 day after. So those timings are very, very important to detect properly.
Yes. So thank you very much. So currently these things have been included in the format that we have, draft format that we have shared, and we have received some suggestions from our members saying that there should be a line on address, consanguinity, hospital and patient ID, phone number, and obstetric history should be used instead of formula, referring doctor instead of center, and the socioeconomic status. So these are some of the very valuable suggestions that we have got, and yes, they'll be quite useful for us in redrafting our protocol. So with that, we come to the next question, Dr. Mohit. Can we know the clinical details? So how much to include so that it makes our report relevant? So I would like to know from Dr. Mohit.
As you rightly said, Dr. Aparna, it has to be relevant. See, we don't want imaging people to just do the scan for the heck of it. We need to understand why we are doing it, and taking a clinical history, a good clinical history, pertinent one, will tell you what to anticipate in that scan. And that also has to be mentioned clearly in the report. So we should begin basically first with the LMP. Now this is extremely crucial that we start with the LMP, and if there's a mismatch, we correct the LMP. So you're correcting the LMP is extremely crucial to put down in the report, like when you can put it down that the calculation has been done as per corrected LMP, because patients need not stick to one doctor all their life throughout the pregnancy. They can jump from one imaging person to the other. So very often we see that there's always an apparent dilemma of a growth restriction because the LMP has not been calculated well. So I believe LMP should stand out, and LMP, if corrected, needs to be mentioned. Secondly, for IVF patients, again, extremely crucial to find out whose eggs were used. If the patient has used their own eggs, we calculate the risk as per the age of the patient. If there's a donor, most of the IVF people use young donors in their late 20s or early 20s, and we are sure that the risk is going to change automatically. So even if we are dealing with a frozen egg, we do want to know when were the eggs frozen, whether it's done before 35 and the patient come to you after 35, this still becomes important to calculate. But more importantly, I believe the clinicians very often write down pertinent history when the patient is sent to you, especially like when you're talking about aneuploid in the previous pregnancy, previous Downs. So that is quite pertinent. We need to mention that we have to have a strong history of preeclampsia in the previous pregnancy. IUFTs that we lost due to preeclampsia. All those become pertinent because you know what to anticipate. That you would want to target your scans this time according to history. Drug history, extremely crucial. So people who are on antibiotics, specifically mentioned, you need to look for heart defects. Now, sometimes, of course, I agree with Chinmay's suggestion that you can't really make the report too big. So personally, I would write down pertinent history. Not all patients come with AMA positive reports, but yes, whom do, then we know what to anticipate, what to look for in such patients. So I personally don't mention a low-lying placenta, patients coming for a low-lying placenta or a bleeding PV. What rather I do is I mention that as a negative sentence in my final impression that there was no subchorionic or a retroplacental bleed. So you can and you should include the most pertinent clinical history that is going to eventually change the way you look at that patient and optimize the information that you would provide an obstetrician.
Right. Right. Thank you. And I hope you're not driving.
I think so.
I am.
Hopefully.
I
So,
got.
Yes, sir.
yes. So thank you, Dr. Mohit. I think despite your driving and being in traffic, you've given such pertinent points, and we have the recording of this, and we're going to include all of those points. So we have received suggestions from our members who have said that we should include drug intake, drug allergies, family history, birth defects, other medical disorders, conception, whether IVF natural, additional risk factors for fetal anomaly, preeclampsia screening, family history of genetic disorders. So I have actually cut down on some of the points and, kind of tried to club. There were a lot more comments. So
Too
history
much
of
to fathom. In the
yes.
the printed report becomes too much to fathom. Rather,
Yes.
you include pertinent points. Yes, clinical history
Yeah.
does get provided by the obstetrician, but very often it is not a dictum that you always provided with history, especially when
Right.
patients come from BMC or they don't know previous history or no genetic workup has been done, they've lost a fetus. So yes, pertinent, yes, you can cut down, that would be better, but only the pertinent should be.
Yes.
And sometimes I think some relevant information might be important also. For example, if you say an early onset eye drops, whether the blood group is negative, what about the ICT?
Yeah.
So these are the relevant negative things also needs to be thought of.
The clinical correlation becomes very, very important, and accordingly we might have to expand or make it more brief. And any previous scan report in this pregnancy if relevant, and that is something that was also mentioned. So I think that is something which is important. So coming to this question, which Dr. Ghosh will take, Dr. Kushagrati Ghosh will take, technical details. How much?
Well, we should keep the technical details to as minimum as possible. That is my one-line answer. Yes, technical details is very important to mention, whether it's a per abdominal or per vaginal examination, TVS. And maybe a one line at the saying that transvaginal was done after explaining the procedure or something like that might be a good idea, instead of really going into that consent taken or written down. I think that would be a far too much. So it can be helpful. Specialized examination, for example, 3D. You can mention 3D, transvaginal, transabdominal. I don't think there is any need for mentioning probes and machines to be used. That would be going a bit too far, maybe showing off also at times. But this is important. Let's go to the previous one. The previous one was important that yes, whether route is important, technical assessment, good. I mean, good is a thing which really makes us put in the hot seat. So I would probably go by the terminology satisfactory. The technical thing was satisfactory. And limited, yes, if it is limited, then we have to mention about high BMI, unfavorable position, for example, for evaluation of fetal phase, oligohydramnios for overall assessment, and others would be also be important for the drop down. So yeah, these are important things, I suppose.
So, as you have suggested, people have not really liked the word good.
Okay.
They have said it should be fair instead of good. And also
I
they
think
have
satisfactory will be much better than fair.
Satisfactory, yes. I think that is
more
really
appropriate.
nice. And we've had some brilliant inputs saying we can be limited. I think that is their day-to-day experience, or dukh, I would say, that limited by advanced gestation, multiple gestation, abdominal wall adiposity, scars, fetal position, anterior fibroid, anterior thick placenta. So we need to see how we can incorporate all of these comments. But yes, these are some things that can make our technique difficult. And yes, if 3D probe has been used, then it might be evident from the images as well. But yes, it is good to mention if it has been used for.
Aparna, in case if we are going in for a report format, I think we can have this as a drop-down list.
Exactly, sir. I just wanted to make a point there. Like you mentioning the probe and mentioning the route of examination may be put in as a technical format so that it's not about showing off, it's not about anything. Sometimes, sir, it's just a documentation that what all you've used in this imaging. Also, when we say it is limited, I think it needs to be supplemented by the fact that whether it was so limited that you could not get the views that were necessary. Sometimes the maternal habitus can be so unfavorable and the baby may be in a breech position, you actually may not get intracranial details. We've had occasions where even at 18 weeks, we've only been able to do some basic biometry and had to call the patient back so that, from the lateral view or somewhere, there are women who've had liposuction and all kinds of things, and it's impossible to negotiate that abdomen. So that is where the balance between the itemized, tabulated and detailed form will come, because you have to say that, well, we took the biometry because bony shadows were seen, but it was not favorable for us to see inside. And if you've mentioned your probes and your machine, at least another person will not say that, oh, maybe they didn't have a good machine, maybe they didn't see that, because that's the other thing that happens. When they go back to the obstetrician, they feel perhaps it was done on a suboptimal machine and they send for another scan in the afternoon. That won't help. So that kind of reporting helps in, again, closing another loop.
Not only that, I think the number of times you scan the patient. See, suppose, for example, I don't see the face or I don't see the fetal heart. I always ask them to sit down and again redo it.
Yeah.
I think that also will help in the sense you
small
are
stomach bubble, all these things.
of,
If you've mentioned that we've seen over a period of time, over
yes,
45 minutes, 3 occasions, we could not see the stomach bubble, that again closes one. So your report should be such that you close it, you don't leave them open-ended.
Yes.
Aparna, can I say something?
Yes, sir. Yes, sir.
Well, this technical assessment, I'm not so sure whether we should be including this terminology limited, because limited scan really means something else. So I think we may have to change the.
Yes, I get your point. Yes.
Yeah. Okay.
We say suboptimal visualization. We write suboptimal visualization, but we could make out biometry and the basic landmarks. Yes. Request for another scan after 2 weeks for better visualization.
So narratives, go into narratives.
Absolutely. So we need to, otherwise it leaves it very open.
Yeah,
Yes.
some points will have to be narrated. For instance, if I say that evaluation was inadequate for a detailed evaluation of the heart and face, and a re-evaluation is requested after 4 weeks. A simple statement like that would actually say why I want to reevaluate, rather than just a generalized saying that evaluation was limited by advanced gestational age and maternal adiposity.
Right. Yes, sir. So we go on to the next aspect, which is the general overview, like how we start the scan on, the other points apart from the baby. So Dr. Pradeep, can I request you to talk about this point? Yes.
Thanks, Aparna. So basically, the beta I'm covering is essentially the fetal environment. And obviously, the fetal environment has got 2 parts. One is the maternal part and other is the fetal part. So essentially, the maternal part must include the uterus, whether there is any abnormalities like fibroids, and obviously any adnexal issues. But basically, it should also include the cervix in terms of the cervical length. And there should be a clear mention about the way it is done, like it's a trans-abdominal or transvaginal. Actually, in any scan report in the general format, we should specifically mention about the way we are doing TAS, TVS, or combined with very specific reference to the cervix. Coming to the fetuses, obviously we need to mention about the fetuses, and I completely agree with the suggestions that we need to actually nomenclature these fetuses based on standardized technique A, B, and C, and in relation to upper, lower, right, or left. This is very important because if someone else is coming next time, they can identify the fetuses in terms of A, B, C, whatever it is. In terms of the viability, yes or no, but there should be another sort of the options of whether it is unsure or something like that. And similarly, as far as the location of the pregnancy is concerned, there should be like the intrauterine ectopic or pregnancy of uncertain origin at the moment. Presentation is valid for second and third trimester. Heart rate, present or absent. Rhythm, yes, there might be an option, but heart rate should be mentioned as well. Fetal movement, present or absent, in the drop-down format. Placenta and liquor is very, very important as far as the fetal environment is concerned. There shall be a mention about the location and with an option of mentioning its distance from the internal os. Cord insertion, yes, it should be there. I'm certain it should be there, the umbilical cord insertion at the right point to the fetus. Appearance, well, yes, there shall be a mention about the appearance and probably mention about the calcifications as we see sometimes in the third trimester and any associated masses. As far as the amniotic fluid is concerned, either both the options shall be there with the maximum vertical pool and the AFI, and there should be a comment, subjective. Sometimes we feel the liquor is subjectively less or more, but when you measure, actually it may come as normal. It is probably helpful to make a comment options in the amniotic fluid thingy. I think, these are the things that I think is relevant as far as the fetal environment is concerned, which will be covered in the general review.
Right, sir. So thank you very much, sir. And I think most of the points have been covered. We did receive some of the suggestions which said that you should be a column for ectopic pregnancy or pregnancy with ovarian cyst and fibroid. We should be saying fetal heart instead of viability. And operator certification with FMF or operator certification should be mentioned at some place. And presentation, because it is mainly changing, it might not be very significant in the second trimester, and exclude viability subjective assessment of amniotic fluid. So these are some of the suggestions out of the many suggestions that we have received. Something to think about and take it forward. So now we come to the next question, which is about the biometry. So this is
just 1 minute. Presentation and position, again, let's not confuse presentation and position with the mode of delivery at this stage. Here we might still require presentation and position because situs anomalies have to be ruled out. So there is a role of mentioning presentation and position in every scan so that you are oriented well to the fetus.
Yes, very good point there. And so we come to the next part, which is biometry. So BPD, HC, FLAC, this is the standard things that we mentioned. So I would like to ask Dr. Shankar to talk about this.
Yes. Thank you. Good evening, all. Actually, during the biometry, there is standard protocol in almost established in every country that we follow it. Like when there is no fetal pole, we use mean sac diameter (MSD), and when there is fetal pole, we start with CRL, that is crown rump length, and that is very specific up to 11 to 13 weeks, 13 weeks 6 days, up to 13 weeks 6 days, we can use crown lump length. Then biparatal diameter, that is BPD, is from 14 weeks onwards. It gives a good idea of gestational age. And then head circumference, which is more specific and more accurate than biparatal diameter after 14 weeks. And abdominal circumference, we take it after 13 weeks and 14 weeks. That may change according to fetus's growth. And the next, we take the fetal femur length after 13 weeks and 6 days. That is from 14 weeks, I think. That's during second trimester, we actually do all the for this by BPD, HC, FL, and AC. That gives us a composite idea of the fetal age, gestational age. Actually, fetal gestational age is changing, and we do it by all these measurements. But there are some problems when there is no previous scan and patient comes up with suddenly comes up with any gestation. Then we have to make up some for it. make up for the previous reports. That is the best measurement to follow during that time. That is from from after 14 weeks we can use HC for a standard measurement for the accuracy of the gestational age. Next, from 23 weeks to 33 weeks, we can use cerebellar diameter, transcerebellar diameter. There is a TCD, which is very, very important. And so I want to add TCD in second trimester scan. And sometimes HL also, because it's a marker of aneuploidy. This is my view on the biometry.
Yeah, so thank you, Dr. Shankar. I think some of the additional points that you've added. So in our, questionnaire, members have responded that, 53% would be going on with this particular parameter. They are adequate. They thought it was adequate, and for some of them, they wanted to add, other long bones, kidneys, cerebellum, TCD, foot length, and then growth charts, clavicle, radius, ulna. So some of these things which have come up in the biometry. So we have to kind of see probably that, if it is indicated to do, what is a standard measurement and what is needed when it is needed. So those are the things that we really decide that what additional things can be done.
Basically, whatever is the clinical situation or the scan demands, suppose you find a skeletal abnormality, I think you need to do the measurement of all the long. It all depends. Suppose you find a ventriculomegaly, then you need to evaluate the other structures like cisterna magna.
Yes.
So it all depends on the case that we are going to do. But then the standard measurement should be, these are the things that we need to.
So Dr. Chinmay, I would just like to ask one more thing about the fetal standards. What should be used? So I put in the questionnaire, when this question was put, around 80% were using Hadlock. So what is the purpose and what is the implications of using intergrowth WHO? Should we be using, should we be not be using?
So Hadlock has been something which has been in clinical use from a long time, and we've really not faced too many problems with it. Intergrowth came up with a study which brought out certain points, and WHO again refuted it, saying that no, it's different in different different populations. So as of now, we use Hadlock. We have not had major issues with it. The thing that we need to understand is customization is a good idea, but customization is limited by the fact that you're customizing it based on the assumption that the parent has acquired his own growth potential. So many parents have not acquired their growth potential because they had chronic ailments or malnutrition in childhood. That is not taken into account in customization. So that's a problem. So whatever chart we use, if we stick to the centiles of that baby, if we date the pregnancy well in the first trimester, and like correcting the LMP, instead of correcting LMP, we fix the EDD. Because correcting the LMP is a fictitious issue, but fixing an EDD is realistic. So when we fix the EDD and then count from that EDD which week the baby is and plot the chart according to that week, and we see that the baby is following its own growth curve, I think we should be satisfied. So some women will be very small, some entire families, they come, they have an average height of like 5 and their bones are always on the lower centiles, but they continue to grow on those centiles. Their echogenicity and length is normal. Then we know things are fine. When things are wrong, we know that the bones are looking curved and there is a definite growth restriction. Yes, sir. So I think Hadlock has been okay for us so far. If we come up with something better, it's okay to change.
Purana sir, what is your take on it?
See, it's very simple. Customization cannot work in a heterogeneous country like India, for instance. We have the tallest, we have the shortest, we have the fattest, we have the stoutest, we have big bones, small bones. We have all shades of color from black to white to all shades of yellow and brown. All races are present over here. We have Mongol races, we have Afghan or Aryan races, and we have everybody. So there is no question of ever using a customized chart. What are we trying to customize? The other thing is that one fact that we learned from the intergrowth chart was that for every single Indian who has a food intake that happens to happen in the United Kingdom, they seem to grow like the whites. Now, that is a fact that you and me cannot refute, because they were like hundreds of thousands of cases that they put together. So there is no question of customization. The question is, which standard chart are we going to use? So whether it's a Hadlock 5, a Hadlock 3, or an intergrowth, depends on what we experience. And we will recommend this on each basis in our recommendations. The word recommendations has evolved during the course of this webinar, and I think it's a great idea to actually recommend it as, and to call them recommendations, and then we will add all of these things. But it's nice to know that some people did also think of WHO, even though they are evolving and they have hardly any patients from India. 1 lakh representative patients from central India is all we got in WHO. So we're certainly not going to use those. And that becomes very important.
I think
One
we
thing I
can
really liked about what
make use
Chinmay
of
said
the-
was, rather than fixing the LMP, changing the LMP, we should fix the EDD when we have a doubtful LMP.
Yes, brilliant idea.
Brilliant idea.
And I think after every of these points, I think we need to add on saying that this is the good practice, so that it becomes a standardized practice.
Right, sir. Right. So we just have, I think, 4 more questions left. I think, sir, we have almost crossing time now, but we have 4 questions left.
I think we'll move fast.
Yes. So, Dr. Sita, I would like to know from you, like, should we be actually giving a list of indications? Because, a lot of societies have given us that, indications for first trimester and second trimester scan. So should we be giving a list of investigations, or should we be, leaving it open? Dr. Sita?
Unmute yourself, Sita.
Dr. Sita?
You're muted. You're muted.
Yeah, now I can. Yeah. I couldn't unmute myself. Thank you. Thank you, Dr. Aparna, for the question. The list of indications, as we said about the reporting, I think it should be a combination of both. So we all know that the bodies have given a fixed indications of the first trimester, second trimester, third trimester, and we know what needs to be seen in the each trimester scans that we do. So that's all there in the background, and we are more or less aware of it. But sometimes they also come in between with an indication for, an acute event where they have a bleeding or an abdominal pain. And I think that is important to mention there, because, if you're doing a mid or a 28-week scan for a patient who's a LAC positive or a previous history of FGR or something like that. So that would be an additional indication that you would add on to the routine indication. So more or less it would cover the routine list that we have, which most of the bodies have given, like in the first trimester, to evaluate an intrauterine or extrauterine, confirm multiples, the chorionicity, and then aneuploidy screening with all its parameters. Whereas in the second trimester, you look at the anomalies in detail and all the other things. And in the third trimester, with the growth Dopplers, multivessel Doppler, the amniotic fluid, and anything else. So as we said earlier, this indication should be added on with a history as well as to what we are looking at in that particular scan, because sometimes that tends to get lost. It is there in the first scan, but when she comes back for the anomaly or later growth scan, if we are doing one, that seems to get lost as to what was the prime factor why she was considered as high risk, or what was the previous obstetric history, which has to be flagged up, I think. So that would also add on to the indication of with the routine growth scan why we are doing it.
Yeah.
I think case pertinent indication is what is important for us.
Right. So from what I understand, so what Dr. Sita and Dr. Praveen sir also want to say is that, we don't need to have a fixed list. There can be standard scans, but we need to mention the indication for doing that particular scan, even if, we don't provide a comprehensive list, and there could be, you do, because then if we provide a list, we are kind of limited by it. So I think that is what is meant here by that discussion. So thank you. And so we asked whether there should be a standard list or an open list. So 50%, 57% said that we should be provided with a list, and 40% felt that there could be an open list. So these are the responses. But yes, as we go on, we need to see how we take things. So with that, we go to the next question. That this was the first question which Dr. Bimal also emphasized, that should impression and clinical interpretation be needed separately? So Dr. Khurshid.
Yeah. Actually, my viewpoint on this is we have to do something which everybody else can replicate in a day-to-day practice. We cannot be very exclusive with whatever we are doing, and we cannot be very theoretical, adopting others and doing the cut-paste job. So to me, in a busy practice, what we do in our day-to-day things is like we try to generate a comprehensive report, and which should be communicative. It should be standardized summary answering the pertinent queries, and also compare it with the previous imaging details and put everything together in the impression. Now it's up to individual practice whether you divide that into clinical interpretation or impression, or just what we used to do in Mediscan is do the impression. Now same thing, we are still practicing, do the impression part and then issue a letter explaining to the consultant about the disease or about the abnormality, and suggesting what necessary steps or genetic test or whatever needs to be done in an appropriate manner. So according to me, we can adopt either of them, whichever suits, but it should be practical, and it should be very, easy to adopt in a day-to-day practice.
Right. So thank you, Dr. Khurshid. And I think you have actually echoed what Dr. Meenu also said, that, you can have an impression and then issue a letter or a referral letter where you explain what are the interpretations. But yes, somehow we need to take this forward, these inputs, and put it together. And the standards for reporting also mention that the impression must be linked with an understanding of the clinical state, their signs and symptoms, and the result of other radiological investigations. So yes, somewhere we need to put forth that narrative thing that Dr. Chinmay also said, that in the end, that, okay, I have these findings, so what do I do with these findings, and what is the interpretation of these findings? So I think everybody is reaching to that kind of a consensus where there has to be a word about that. So yes, a majority felt that there should be needed separately. 53.1% said that yes, there should be a separate column for that. So we again come to Dr. Sita. Ma'am, would you like to say that, in the additional comments and disclaimers section, so what should be added in the disclaimer section?
Thank you again. Disclaimer is something which people are very fond of, and it's actually a statement which absolves you of a responsibility. So which is actually not, it's contradicting. The minute that you write a report, you sign on the report, you're taking responsibility for that report and for that patient or the fetus. So but of course there will be disclaimers that, sometimes you can all anomalies, the evolving anomalies cannot be seen on the early anatomy scan or the mid-trimester scan. That should be mentioned. And of course, in our country, we will not be talking about gender. So that should be mentioned. But whatever you write, it is not going to help you in the court of law, as we will hear again. But I think disclaimers should not be a big page of disclaimers that you sort of lose the whole purpose of doing the ultrasound. Just the basic disclaimers that are relevant. And again, because it is individual as well, you cannot generalize one disclaimer for everything. It could vary depending on the individual patient you're scanning or the indication you're scanning as well. So that's why a disclaimer is there important, but it should not, you should not completely base your report on that disclaimer. Thank you.
So thank you. And thank you very much for raising that point, that even if we write a disclaimer, that does not absolve us of the medical legal implications of a report.
Can I, Aparna, just add a sentence on this, that what happens is, some specific disclaimers can be used as disclaimers, like, which are routine. But when it comes to specific things, I personally feel that, because disclaimer, nobody reads, honestly speaking. It's like after your impression, you can put in as to note or something where because in that specific condition, we want that to be read. We want the patient to read also about it, When it comes as a disclaimer, like how many times have you read the disclaimers which come in a lab report? Nobody reads that. So specific things, when it comes to, they may not come, don't put it under the heading of a disclaimer and put it, pertaining and maybe in the at the end of your impression itself.
Sorry to interrupt, but I have had some patients who actually read that disclaimer and they don't understand what it means. And it says, what does this mean that we've not picked up all anomalies? What it is? So there are people like that as well. So
I know. I came to, one of the patients said that the doctor says that nothing can be detected. So if nothing can be detected, then why has scan been done? So, there are people on either way, they do read and they don't read. But then see, to safeguard ourselves.
So, sir, my point was that when we want to, in a specific case, when we want to say something, let it not come as a disclaimer. Let it come as a part of your impression and this thing itself.
I know.
Sir, and I must tell you, the most interesting thing is that this part has the maximum suggestions. I think that is the things that they have gone through, and that we actually face in the
because we are all scared of the legal implications.
Yes.
Defensive practice, yeah.
Yeah, so there have been lots of comments. Actually, I have pruned it down, but yes, there are a lot of comments on that. So
I think one thing which will bring down the number of disclaimers is a pre-test counseling sheet. I think that should come as part of our anomaly scan recommendation, that there should be a patient information leaflet which needs to be given to patients before they come for the anomaly scan.
And they will go away, they won't come to you.
No, sir, they will. And
I'm joking.
because let them know that this is the limitation. So if they know that is the limitation, then they come within that limitation. The problem is that they come with that fancy idea with all that and advertisement that happens nowadays. They think, I mean, it's everything is going to be seen there. They even want the shade of
The first question they ask after the scan is everything okay?
Normal.
Difficult question to answer.
Absolutely. So, Dr. Krishna, yes, Dr. Krishna.
Yes, raised his hand.
Have you raised your hand?
That's what it says.
Right, but I think.
I don't think he's able to unmute himself. Let me just do that.
Can you
unmute Krishna?
I think he's yes, Krishna, you need to unmute.
Yeah. So my point is that this should be an honest, transparent report, and in the impression we should mention every verbal communication what we have with the patient, as well as to the doctor, the referral doctor, because whatever we say verbally, actually that does not hold in the court of law. So whatever the counseling we have done to the patient, it should be documented in the report in the end.
Right. Yes. So I think that is what we all are looking at, that every documentation should be complete, or the documentation of every communication should be complete. Yes.
Yeah. Thanks.
Yes. Thank you, Krishna. So now, Dr. Meenu, would you like to tell us what are the requisite record keeping images? Because this is something that is very, very important, for the present, for the future.
Yeah, so I mean, as a lot of people have always been reiterating that if there are no images, it just extrapolates to the fact that you've not performed the scan. So keeping records of this images of the scans that you have done is very important. And sometimes unknowingly or knowingly, we end up taking 56, 80, 100, 150 images for the anomaly scan. But at least, even though it is difficult, at least there should be a set of, once we come up with the guidelines and the protocol, I think a minimum set of 25 to 30 images of the, whichever are the necessary planes should always be maintained. And if you find that there is an abnormality, now as we always follow a principle that, if you're differentiating with the fact that whether it's an abnormality or an artifact, you should be able to demonstrate that particular finding in two planes. So demonstration and storage of the images in at least two planes, especially in 2D, and if possible in color, should be done. And if you can store a video of your abnormal finding, then nothing like that. I know it's a cumbersome task, but then tomorrow if somebody raises or points a finger at you, say for example, even a small, I would give an example out of a personal experience. There was a very small anterior abdominal wall defect, a very small omphalocele that we had picked up for a patient, and the patient was referred to it as 24 weeks. Now we did the karyotyping, everything came out normal, and then the patient went to another tertiary center because we were counseled that there's a small probability that the patient might require a surgical correction. Now, when that patient went for a follow-up scan to that tertiary center at 32 weeks, they did not find anything. And their doctor actually called us back saying that there is nothing with the patient, and so what should we do? Now, fortunately, we had a video clipping of what we had seen, and therefore we were able to convince that clinician that no, this is something that we had seen, and this is something that a small hernia probably was just involuted back. So I think for pathological findings, images in two planes and at least a video of the abnormal finding is mandatory. And for the normal scans, at least the basic planes, as per whatever guidelines you're following, you should at least put the images in your archive and save it.
Right. Thank you, Dr. Meenu. That is what we should be doing. And now with this, we come to the last question. Sorry for the number 15 before number 14. So, sir, this is the last question. And, as usual, I like to give you the toughest question. So what are the medical legal implications of reporting, of doing an ultrasound, of documentation, like the bigger perspective?
Yeah. So the fact is that for every report, there are two aspects. There is the clinical aspect, which is useful to the patient and as part of standard medical procedure. The second part is when there has been what patients love to refer to as deficiency of service, callous negligence, blah, blah, blah. For that, we have to be very careful because it's the forum that they go to is the consumer forum and not any other forum. The consumer forum consists of two types of individuals: those that have a judicial background and are qualified and experienced in the judiciary, and those that have absolutely no such background and are just citizens that are presumed will have an appropriate judgment. There are no guidelines for appointing people to these so-called consumer forums. There are random people who are allotted, and the guidelines are lost somewhere in the bottommost shelf or the topmost shelf or someplace where nobody can find them. So we have to be careful that what we present has to come straight in the face and hit them in the face. So we have to hit them in the face with this because we are not left with a choice. There are too many frivolous cases. And unfortunately now, with the social bias against the medical profession, every doctor is being told that they did a wrong job and they didn't do an adequate job. We mentioned limitations of the number of anomalies that can be detected. We mentioned Eurofetus study. We mentioned anything. They said, no, how can you miss an arm? Well, an arm can be missed for many, many reasons. So therefore, there are medical legal implications which we have to address. There is no question. So we do need all of that we have discussed. That automatically becomes so. The next thing is that we will have to have disclaimers in some form or the other, which make it clear either in the body of the report, in the conclusion of the report, or as a separate disclaimer that biology is not an exact science. I mean, we have to start from that point really to tell people that biology is not an exact science. It is a science where you have things that you can miss. And we'll have to find the right word and the right sentence for that. The next thing that we have to make sure is that the fact that you can miss anomalies should be very, very clearly mentioned in that, because nobody listens to you when it comes to that. Also, when you actually present the evidence in court, the only evidence that the court really accepts is the report and the images for whatever they are worth. Now, obviously, in a country like ours, we cannot afford to give 56 images. The kind of money that doctors get paid by the population, it makes no sense. If we give videos, we get hit by PNDT, which says you showed the sex on the video. That leaves us between the devil and the deep blue sea. So what do you and me have to do? We have to have a written report that makes complete sense, which can be the longest possible report if necessary. But we know that from a clinical point of view, we can't have one report for medical legal and one for this. But that it clearly indicates that there are limitations and these are the limitations, so that tomorrow they can say that, look, the patient was told. Now the question is, the patient says, I was not told. So for that, it becomes necessary that we introduce a form of the kind that Dr. Chinmay was referring to, that there is a pre-test counseling form where she clearly says, I have read this form and I have now understand the limitations and the utility of this ultrasound scan, and I'm willing to have one, and it's signed by the person who is accompanying her. So I think that will form a very important part of our medical legal aspect, that we do have a form like that. We will consider it in our deliberations in the next few months, and that the patient and a relative will have to sign that they have read that form, that they have understood that form in a language that they can understand, and it's almost like an affidavit. Then everything will be complete. And of course, then the frivolousness will also stop. And we won't have to keep on repeating everything that, yes, in the Eurofetus study, in this study, in that study, etc., in the Mayo Clinic, this case happened and so on. That is the way we have to go about it. And we can't soft tread on that. We have to hit them hard.
Right, sir. So very nice points. And I think we really need to work on all of those points so that, we are very, very clear when it comes to the court of law. So just going through this medical legal issues in obstetric ultrasound, it's a beautiful article which actually says why do legal suits happen to ultrasound. So when the anomaly was not diagnosed or significant or contributor factor in case alleging negligent obstetric care with resulting damage to the infant, plaintiff or the mother, specific in India would be the wrong side of the PCPNDT Act. And potential areas of negligence could be guidelines, instrument and safety, documentation, indication, examination content, or quality control. So these are the areas under which we really need to tighten our form, as we said, as sir is saying that we have to hit it hard. So these are the points where we should be very, very stringent. And when we make a document, if all of these things are under control, then we are really safe. And so we've got like real number of suggestions on the medical legal validity. And we cannot say that it's not a medical legal document. It is, because the report is something that is going to save you if you've done it properly. So I think that is something that we really need to mention. So coming to so I think with this, the work ahead is that we need to develop templates for the first trimester, the second trimester, the third trimester growth scan, and the ultrasound for placenta creta spectrum, and anything else, all the suggestions that is going to come forward. So we do have a long road ahead. So thank you very much. And I would invite your comments. Thank you so much.
Thank you so much, ma'am.
So yeah, go ahead.
One question. Yeah, ma'am.
Questions?
Sir, we were talking about the growth charts and all that. So we have got certain kind of Indian standardized charts and all that, for the Indian standardized population. Should it be included in the customized chart? I don't think so. Or we should adapt to that, or we should adapt to something else.
Yeah, I think basically the Indian customized charts, once you say a customized chart, that itself is a limitation. I think we have been following these Hadlock charts, which are absolutely good, and we have never had any problem with it. So I think it's better to adhere to it. Maybe basically, see, we have certain patterns that have been developed, which we know to follow, and as far as the growth is concerned. So it's better to follow that, because as Ashok said, customization, about what customization? I mean, in what way are you customizing it is the question that we have to answer before we really customize a chart. So I think that should be very carefully addressed too. And there are a few questions. I don't know whether we have time to take them, or what do you say, Ashok?
The plan was to note down all these as suggestions.
Okay.
And then we will take them up in future forums.
Yeah.
And also there are some very, very important suggestions that are open to a full-fledged discussion. And the aim was that we will make sure, we've taken screenshots of the entire thing and transferred the whole file. So we will then address all these points.
Yeah.
And every point is a very relevant point, and we will include all of them. So they're not straightforward answers to most of these questions.
Correct.
And it's going to be part of our actual activities as we go forward in this series of webinars and in this series of core groups and the whole task force.
Okay, good. Thank you.
So
before we stop, I think we should congratulate Aparna for organizing such a wonderful, meticulously planned.
Really, Aparna.
Fabulously done.
Precisely.
A lot of hard work done and very meticulously put it all.
Yeah.
And we've had fabulous inputs from our members. We've had fabulous inputs during the program. We've had fabulous inputs during the Google Forms, and there will be more Google Forms. We will give you more time to fill the Google Forms. Equally importantly, this idea was absolutely brilliant, and I want to thank Dr. Kanchan Mukherjee and the entire group
Calcutta team.
of our Calcutta regional chapter for putting this together, for sowing the seed and making sure it grows into the right tree. And it's something that will take us a little bit of time. We've had some controversial inputs, some straightforward inputs, and we will make sure that we will weigh each one of them and have a document that suits us as a profession, point number one. It serves the patient's purpose, point number two, and that it reduces the amount of unnecessary litigation at the level of the courts, because our poor consumer forum does deserve a break.
I think
we are grateful to everyone involved here. The way we got supported by the entire SFM team across the state, we are really overwhelmed with the support. I never realized that there will be so much of support and acceptance on this topic. Thank you, everyone.
It's a family prestige.
Absolutely,
And
absolutely.
thank you, Dr. Khurana and Dr. Praveen, for entrusting this very important task to the Kolkata chapter. It's such a fabulous, it's really a dream come true.
And once it works out, then I think we will have the wonderful, till now we have all sorts of reporting formats as far as radiology is concerned, radiology and ultrasound is concerned. But pertinent to fetal medicine, I think there is nothing like a very specific reporting format that has been developed. I think if we can develop under the SFM banner, I think it will be wonderful.
Yes, sir.
Thanks so much, everyone, for being here tonight. Yeah. And I'd also like to thank Vishal Mittal for always being there, and also Conferences International for organizing the webinar impeccably as always.
Thank you.
Thanks so much, everyone, and a very good night.
Thank you.
Thank you.
Thank you, sir.
Thanks, Aparna. Thank you.